All right. Hi, everyone. I don't know a lot of you, but I will. I'm Jensen. I work with these guys on faculty. I am a little bit weird because I do half and half between the general hospitalist group and working with you guys. But I'm going to be slipping into the APD role, so if you guys need anything. Prior to this past year, I was here for 6.5 years, so I know where all of the hidden staircases are. So if you need anything, just let me know. I also am a proud graduate of this program, so if you have any questions about anything like that, I'm always around, probably more than you will want me to be. So just reach out. My office is on the 7th floor in the main hospital. So I do mean this genuinely. Chattanooga is a very special place. As somebody who just moved back here from some time away, I have a renewed appreciation for a city that I already really, really loved. And we are glad you guys are here. So my two things I need to talk about today are, I got all the sexy topics, new kid on the block. So I'm going to talk about scholarly activity from a requirement standpoint and from a where to look standpoint. And then I'm going to talk a little bit about handovers and IPASS. Feel free to stop me at any time. Okay, so scholarly activity is a core ACGME requirement of all programs. It is not everyone's chief reason for going into residency. Some people have varying levels of interest in it, and that's fine. But you are all here because you want to become board-certified internist or something that requires you to first be a board-certified internist, so you need to know this. There are also a lot of ins and outs to doing research at a place whose primary focus is not research. So we'll be very frank about the fact that Erlanger and UT Chattanooga, our primary focus is patient care. We put you guys in the trenches. You see the sickest of the sick, and we're very, very good at that. The research stuff does not get the attention, in my opinion, that we would sometimes like it to get, but that is improving. We have recently hired a full-time Dean of Research, Dr. Pizzorno, through the college, so he's a great resource and is doing a lot of things to get us some more resources and some more funding towards scholarly activity. But reasons for discussing it, so it is a core program competency, and I will talk about the specifics of that just so that you know what boxes you need to check. It is a graduation requirement, so again, referencing you back to the program guidelines. We want to support your postgraduate goals, whether that's to go into academics, to enter into a fellowship, whatever you want to do, and knowing that some postgraduate goals require a different level of research than others. We also want to teach you how to think differently. So you have a renewed appreciation for how you consume literature, how you look at guidelines, how you treat patients, if you have an understanding of the process of doing research, particularly as it comes to the clinical standpoint. I personally have an interest in critical care. I also have done some stuff with some of the big national data sets, looking at NHANES stuff. So that's just my personal background. I am by no means a PhD scientist. I'm by no means hyper-published, but I do have an interest in it, and am happy to try and help you with whatever your interests are. And again, no matter what you're doing, no matter what your goals are, you're going to be consuming medical literature. So understanding the process is really important to knowing how to critically review literature and knowing what you should make of it. It also is a reputation builder. It's a reputation builder for you personally. It's a reputation builder for the program. You could give an entire lecture about how much weight should be put on that, but it's the way of the world. It's the way of the medical community. And then you also want to give back to the scientific community because that's really what it's all about. If we knew it was what we were doing, it would not be called research. So that's also just to say to you, you don't have to be a professional. Everybody starts somewhere, and like I said, we're going to try and help you meet your goals, whatever those are. So the role of the program, again, I talked a little bit about we have some great strengths here, and we'll talk a lot about that. But being on the smaller side of programs, we can give you one-on-one attention. We can help you meet your individual goals. You're not a cog in a machine. We're able to be there for you personally. The mentorship that Dr. Davis talked about is an important part of that. So, your primary mentor may fit really well with what your research goals are, but it's not uncommon that, particularly if you have a specialty interest, that you find and seek out somebody who already has research going in the area that you're interested in or is practicing in the area that you're interested in. But mentorship is a huge role. I'm also going to do, starting probably in August, the didactic curriculum about research methods, which I will try not to make as dry as it sounds. But the bottom line is that you need to understand some basics of statistics just to be a functioning physician. It's entirely too common that people don't know the difference between a t-test and a chi-squared by the time you fill your brain with all the other stuff you are. So I'm going to do some refreshers on that. It will be very basic, but that's coming down the pipe. And then as far as opportunities, so research is a networking thing no matter where you go. There are some general college resources. There is a research section of the UT College of Medicine Chattanooga website. That's a really good portal for IRB related information, particularly forms and dates and when does IRB meet. IRB meets every month. You have to have your stuff to them 2 weeks before they meet, but you do get a pretty quick answer after they meet. So be on the lookout for that, because I've more than once had something ready to go and didn't make the deadline, and then all of a sudden it's 6 weeks till the next one. So keep that in your head if you have a project that you're interested in. I'm happy to help guide you no matter what your interest is through the IRB process, because it's just a whole bunch of paperwork. But it's not rocket science. It's just making sure you have the right forms. And then we're also happy to give you feedback, even if it's a project you're kind of doing on your own or doing with somebody else and you just need a read over. So that's the role that we play as a program. So research is not one size fits all, particularly as it comes to scholarly requirement. This is not my kid, but my kids are cute. It's not, so we'll work with you on what your interests are, whether, if you have, if you're really very clinically focused and are really not very interested in research, that's okay. But my goal is for you not to phone it in, but for you to find something, whether it's QI or process improvement or teaching, that fulfills that requirement and is still meaningful for you, rather than just phoning in a case report at, a super local meeting. I mean, there's nothing against case reports, but it's, I wanted you to do something meaningful for your life that also meets your goals. This is cut and paste from our program requirements. So this is the ACGME's portion of the research and scholarly activity requirement. So it must advance their knowledge of basic principles and sorting how it's conducted. They have to participate, so this isn't optional. And then we should give you guys some tools with which to do that. So these are the 3 core things that ACGME outlines. You can see that's not particularly specific, and so our program guidelines go a step further. So this is of last February. We are going to talk to you more about the QI component of your research requirement, because there is a QI component in addition to the general research requirement. But here listed a couple of your options. It looks like this is a small list, but these are there's a lot of branches under each of these. So manuscript or book chapter publication, so anything published in a peer-reviewed journal, we'll check that box. Presentation, so even if non-published, but it does have to be original work. You can't present somebody else's stuff, not that you would ever do that, but at a reputable meeting. So a lot of people, the Tennessee ACP meeting is very big around here. There's a lot of other subspecialty meetings, but if you are personally presenting, that will fulfill your requirement. And then you can do a teaching component, which we've kind of tightened up on a little bit, because it should be something meaningful. So it can't just be like, hey, I reappropriated a morning report and gave it to 5 nurses on West Wing 3. That's not nonsense. So, but if you want to do some sort of local workshop, if there's something you're passionate about, if there's something that the community feels like they need, public health is my other love, and that's what I was doing this past year. And so if you have something that wants to meet that, we're happy to work with you to make sure that that's something that can go in this box. And then giving a grand rounds is another good thing. I think giving a grand rounds is also a good life thing, because it's a big deal. A lot of people come, and it's a pretty high standard of presentation. So learning how to give something that's that well researched to a larger crowd, I think is a good public speaking experience as well. So those are some examples. Again, if you are curious about if something would meet the requirements, just ask. This is something you need to think about sooner rather than later, and I know that everybody's saying that about everything that you're learning now, and you're like, I'm trying just to keep my head from exploding. But just kind of keep it in your head. Don't push this off till 2nd or 3rd year, because research is slow. it takes months and months to get something off the ground, and then if you're waiting on funding and if you're waiting on IRB, time can get away from you. So particularly if you're interested in research in the more clinical avenue, like think about it more on the front end than on the back end. But if you have any questions or you are wondering if it's going to fulfill the requirement or if you have a particular passion area, just ask. So again, quickly on QI projects, this has been a little bit of an evolution. We had a faculty member that was really passionate about this, and she had to move to be with family, and sort of around the same time, the GME here changed some of their requirements. So we are going to work with some of the evolving guidelines to make sure that what we're asking you to do is also meeting those requirements so that we're not giving you busy work. But we will keep you guys posted. And this is a PGY 2 and 3 requirement. So this you can put on, I won't say the back burner, you can put it on the middle burner. So stay tuned for that. Okay, this is my kid. So take a point. So work with your mentors, either the ones assigned to you or the ones that you seek out. You can have as many mentors as you want. Dr. Davis does a fabulous job with the mentorship program, but again, there's a kind of primary mentor and a secondary mentor role, and so work with those to make sure you're getting something out of it. Follow your interests, follow your passions. Research is much of the time like beating your head against the wall, and it helps tremendously if you are passionate about what you're doing. I have a project I started in 2016 that got grant funded last year. So just be persistent if you're passionate about something, because it can be really worthwhile. Don't wait until you're in the middle of your third year to think about this, because you won't get it done, and don't be afraid to ask for help. Anybody have questions about the scholarly requirement portion? It is pretty straightforward, but it's amazing how much gray area can be created eventually. So, but absolute requirement. Yeah. Yeah, so that's one thing Dr. Pizzorno has been passionate about, and I can speak to this personally because, again, it used to be, I won't say impossible, but it was really close to impossible, especially as kind of a lower person on the totem pole to get funding, but that is changing. So the grant that we ended up getting, Dr. Davis got some grant funding from the same program. It's actually a combination with UTC, so we do a lot of work with their statistics and mathematics departments. And we have a formal partnership with them. So it was a partnership grant on kind of joint projects. But there are some, and some of that is on the research website, and then they'll also periodically send out emails about that. And then there's general grant funding. So if you have a particular interest, American Diabetes Association has grants. All of these places have grants, and we're happy to help you write some of those. Dr. Davis also has some experience with grant proposal writing, and then there's also some third parties that can help look over that stuff as well.
I know Dr. Cohen does some QI stuff in the ICU.
Mm-hmm.
Who else would be leads in the QI center?
There's a sign that says, please repeat the question. All right, so the question is, Dr. Cohen does some QI stuff as well. I think we're trying to figure out who is going to head up QI kind of formally. But I think it depends on what your project is, to answer your question. So somebody whose primary area is whatever you're interested in. So if it's a general medicine stuff, your core medicine faculty are going to be the people to go to. And the same goes with faculty as goes with other stuff. You want to find something that the faculty member is also passionate about, because everybody gets busy. So I think it depends a lot on what your interest is, for sure. And I think we're going to work with some of the other core faculty members just so you'll have a point person. But for now, feel free to come to me. I'm happy to help, or at least plug you in with the right person. Good question. Yeah, and the first question was about funding for those of you tuning in at home, although you should all be here. So. All right, what else? Good questions. All right, cool. All right. So we are going to switch gears and talk a little bit about IPAS. All right, I'm going to do this and then pass these around so you guys have these. Okay, so raise your hand if you know what IPAS is. Nobody. Okay, know what it is? Okay, have you used it? Okay, that's okay. Sometimes it's easier if you haven't used it, because then you can learn how to do it the right way. So IPASS is a formalized, very well-studied handover framework. So I'll let you guys pass these around first. It actually started out in pediatrics, but they were able to demonstrate some pretty impressive improvements in, yeah.
Is there another one?
There were exactly 10. Okay, there were exactly 10. I might have dropped one. Will you look, sorry, remind you your name, right there. Yeah, what's your name? Brandon, will you look underneath the seat where I was sitting? Yeah, okay, I was like, okay. I don't have a lot of skills, but counting to 10 I would put in on my resume. Okay, cool. Everybody got one? All right, so high reliability organizations, meaning organizations that shoot for zero harm, is something that's very, very well studied. We sometimes think about quality stuff as being a little bit on the softer side, but organizations that have done this have put the effort into it, have put the resources into it, and have changed the culture of their hospitals, have significantly fewer adverse events. So at the end of the day, if you think this isn't a patient care issue, you're wrong. And handovers are a huge deal. They're a huge deal because we hand over, I'll try to shoot for you today. We hand over significantly more than we used to when we didn't limit how much you guys worked. And handovers are a big deal. So this is root causes. This is all that it still holds. This is from a Joint Commission statement, but root causes of Sentinel events. So those are two just vocab words, but root cause analysis, some of you guys may have seen, is a formal exploration into an adverse event. A Sentinel event is one of a handful of what are considered never events, so things that should never happen to patients in hospitals. It should, no matter what, should never happen. So anytime but these things do happen. Shooting for zero harm is aspirational, but it doesn't mean it shouldn't be a goal. So you can see the most common cause of a Sentinel event was a communication error, above everything, above an environmental issue, above a drug issue, above a judgment decision, above everything is communication. So it's very, very important that you do this correctly, and this starts with your intern. Here it starts with the first time you're taking care of patients for real, and this is just, it's really, really important. So the goals of implementing an IPASS system are first and foremost to improve patient safety. It's a high-risk period when you're handing somebody over. It's a high-risk period where somebody who doesn't know that patient is taking care of your patient. We have smaller teams here, so there's going to be times where the primary person taking care of that patient is off. So it's important just as much for your team as it is for everybody else. We also want everything to be as standardized as possible. When I introduce this, it is going to seem like the most inefficient thing that you've ever seen. I promise, and this has been studied, that when you get good at this, your handovers will be more efficient. They will initially take longer, but everything's going to take a long time in July. You're not alone. Everything you do, you will spend 20 minutes writing your first Tylenol order. Like everything takes longer in July. So stay with it, because eventually it has been shown to actually reduce the amount of time and increase the quality of handovers. We want this process standardized across all teams. You guys are empowered by me, by Dr. Stone, by Dr. Carey, by all the faculty to hold your upper levels accountable for this as well. We implemented this last year, so it's relatively new even to the whole program, and we don't want anybody to get lazy on this. And you are welcome to hold us accountable for it as well. We're not going to be handing over directly to you, but we need to make sure that we're helping with that. And then you also want to know how to succinctly present a patient and how to gain some degree of situational awareness. So these are two skills that are very hard. And you'll recognize this as you work with other residents. You'll understand that when you are on specialty services or working with fellows, it is a sign of maturity, it is a sign of clinical competence to be able to succinctly hand over a patient. You should be able to tell somebody in a few sentences everything they need to know, because you know it's important and you know what they may need to know. And IPASS is a good tool for honing that skill, because it's a hard skill. So you'll notice that when med students present or when interns present, it's very long and it's rambling, and you get to the end and you're like, how do I still not know what's going on with this patient, because you just talked for 15 minutes? And that's okay. That's why you're here to learn. But IPASS can help with that as well. And then situational awareness is really important. It's a tough skill to understand and to know and to vocalize when somebody's sick or has the potential to get sicker. We also want you to take pride in this. This is a pride point. We want you to do quality work. We want our program to put out quality work. It also, when you are on night float, you will appreciate this because you need to take care of your night float. They're very busy. They're covering a lot more patients than you are during the day, and you want to make sure that they have the information they need, and you want to take care of your patients. This is from the retreat 2 years ago. Okay, and again, we're not going to try and make your lives harder. It will be cumbersome at first. I fully acknowledge that. But once you get good at it, it is better. And this is funny, so I tell all my non-medical friends. And then a big part of this, and there's a lot of things that are spokes off the iPass wheel that I'm not going to spend a lot of time on today, but you want to create a shared mental model. You want when somebody you hand over a patient to thinks about that patient that they have the same general sense of them that you do. And that's hard for somebody who's never seen that patient. So trying to stick to a pretty strict model helps with that. And then closed loop communication is a big part of it. You guys have seen this. This comes across again. I'll talk a little bit more about code stuff, and Dr. Shaw will also talk about the sim lab, but this comes back to general closed loop communication being part of the equation. So it all comes together in handoffs. All right, anybody have questions about that before we talk about some specifics? Okay, moral of the story, it is important. Okay, so some qualities of effective handoffs. So you need to know who's doing what. This gets a little bit gray sometimes in the beginning. Seniors, especially seniors that are new seniors and we're just interns, tend to want to interject and be like, oh, they meant this, or they meant this. You need to know who's handing off and who you're handing over to. So you don't need to be handing over to a huddle of people. You don't need to be going back and forth with somebody else. You need to know that I am handing off to you. And that's an unambiguous transfer of responsibility. So when you transfer over a patient to another person, they need to know that they are now responsible for this person, which is why you can't do group to group. You need to protect your time and your space. This is hard, but it's really, really, really important. So if you have to be in the emergency department to hand over patients, don't do it in the middle of the hallway. Not only is that a HIPAA thing, but you cannot focus down there. Like, it's just very hard. So if you have to step over into a side hallway, do what you need to do, step over into a curtained area. Ideally you'd be doing it in our handover room, but make sure you're protecting the time and the space. Don't be doing 7 other things. Pages will come in, but try and as much as you can protect the time and the space. Use the standardized format, which we will talk about. Make sure that and this is more of an issue with written handoffs, but make sure that they're up to date. So you will have patients that will hang out with you for weeks on end. And it's easy to not look at their written stuff again, but you need to make sure that they're up to date. You need to make sure that you don't have meds listed that they're not taking, tests pending that aren't pending. Make sure everything is up to date. You need to know, and this is a little bit in nuance, but you need to know if people have particular ways that they receive information better. You need to make sure they have something physical to look at while you're talking. Take into account their level of training. Handing over to a senior is different than training over to an intern. And then again, you want the person receiving the information, and this goes for you guys who's starting on nights. All right, so this goes for you to start off with. You're going to be receiving this more often than you're going to be giving the handover, so you're not a passive participant in this. You're an active participant in the handover process. So they should be face-to-face. Again, you don't hand over on the phone. We don't hand over through Tiger Text. Under no circumstance should you be doing that. There are times where attendings will receive information over the phone, but that's not a formal handoff. Your formal handover of patients should always be face-to-face. It should always be structured. We'll talk about the structure some more. Work on your pace. This is hard. It's really easy to rush through certain things, or the other thing that will happen, again, at the beginning of the year is people are, I don't need to know what they had for lunch last Thursday. Like, you just, make sure you're trying to strike that balance. And then, again, beating a dead horse on this, but closed loop communication and creating a shared mental model. All right, so the printed document should, and we'll get you guys some examples of all of these, but it should supplement the verbal. It should have something for them to follow along with. It is more comprehensive, but it still needs to be succinct. Don't write a novel. And it needs to be accurate and up to date. Use your seniors to edit them, make sure they're looking over them initially. That is something you should grow out of, but until you feel like you've gotten the hang of it, that's what your seniors are there for, and that's especially important early in the year. All right, so again, long list reiterating, but you're going to overview. You need to have an appropriate environment. You're using iPass. You want to be as concise and focused, and then contingency plans. And we'll talk more about this, but contingency plans are really, really important because it's not just anticipating a problem, but it's knowing what you would do about it. All right, so iPass. I, illness severity. We're going to go into each of these. P, patient summary. A is your action list. S is situational awareness and contingency planning. And S is synthesis. So S is the most active part. The receiver of your handoff should always feel comfortable going back and forth with you during the course of it, but there needs to be a formal portion at the end of your handoff where the receiver acknowledges what they have just heard. All right, so we're going to go through each of the letters really quick. You guys will have these cards. These cards clip on your badges, so I would suggest just clipping them on there at least initially so that you have something. And it's okay to pull it out. Like we're not going to laugh at you. It would rather you pull it out and do it correctly than not. So illness severity is a continuum. It is a honed skill, but it is a very quick part of this mnemonic. So you're going to start off with, this is a 57-year-old stable patient. This is a 58-year-old male. He's a watcher. This is a 63-year-old female. She's very unstable. Now, this is a matter of opinion. There's no right answer to this. But if any member of the team has a gut feeling that that patient is at risk of deterioration, they need to be put in this watcher category. So stable patients should be truly stable. And if that means that you're putting more people in this category in the beginning of the year than you do later in the year, that's fine. And if it's somebody else on your team feels like they're in this watcher category and you feel like they're stable, err on the side of putting them in the watcher category. And, you know, ideally you would have some objective evidence for this, but sometimes it's just that you know this person and they really didn't look good today. You know, their labs may look okay, their vitals are fine, but you don't have a good feeling about them, put them in this middle category. Unstable patients are truly unstable, so I would put those patients at risk of needing a transfer off the floor or with something that is volatile in some way. Does that make sense? Yeah.
Does the terminology change a little bit for ICU? The way people describe like a patient's...
Does the terminology change for ICU? Yes. So is ICU formally using this? Yeah, we're going to kind of formally integrate that as well, but at this point, you know, they're technically their own department. So yes, it does. But when you are transferring patients out of the ICU, so if you're on the ICU service and transferring them to the floor, you should use this for transferring them out, and you should use it in this way. I have used this in the ICU, and it is different because you don't have that component of should they go to the ICU, they're already in the ICU, and your standard of stable is different in the ICU than it is on the floor. So it is relative to your environment, for sure. Any other questions about I? This is the easy one, so we'll keep it. All right, so this is hard. The P is hard. It's a patient summary. So it should succinctly describe why they're in the hospital. It should very succinctly sum up what led to their admission. So not like they were feeling bad last month and then they went to their PCP and then they went to the urgent care. It should be 57-year-old male, started having chest pain on and off the last month, presented on this day, diagnosed with this. The hospital course should be very brief and only relevant to what's going on now. So some of these patients will have very long hospital courses. It's important to acknowledge that, but you don't need to go into the ins and outs of each hospital course. Ongoing assessment is what is active with them right now. So even if he came in with chest pain, cardiac workup was negative, would be the hospital course. Turns out he had a PE. This is what we're doing for now. So active problems and diagnoses, things that you're doing something about. And then plan is basically what you're doing with those active problems and diagnoses. Again, you do not have to get in the weeds on this. If you tinkered with their labetalol, I don't care. If you started them on labetalol, that may be worth knowing in case you get called if they're hypotensive or bradycardic. You know, so think about the things that are going to matter. Yes?
Yeah, so if you're handing off to someone who knows the patient, for example, if it's just rotating days and nights,
Mm-hmm.
do you take the liberty to abbreviate, or do you assume others in the group need to still hear the information and you do the full sort of formal handoff?
Yeah. So the question is, if somebody else knows the patient already, does it change? So the answer is yes and no. So you always need to go through all the letters. You don't need to ever skip letters. Can it be abbreviated? Yes, somewhat. When you're going from days and nights, though, those are separate groups. So even if the person admitted them, they have no idea what's going on during the day, and they're also receiving a lot of patients, so you can't assume that they remember the details of that patient. So you do not need to skip steps. You will run into situations where, particularly for patients that are with us for a long time, if somebody else has personally taken care of that patient and not much has changed, that's okay to say in this portion. So you can say, this is the guy that came in for cellulitis 3 weeks ago and has uncontrolled schizophrenia and is homeless and is still with us. Nothing has changed with him. His medications are stable. We're just looking for placement. That would be a perfectly acceptable way to summarize them. But notice that I still said why he came in, what his primary problems were. We're not changing anything on him, and this is what we're waiting on. Okay, so you still had all the points, but it was less than a sentence. So yes, it's okay to abbreviate. You got to know your audience, though. So just because somebody has met that person doesn't mean they have any idea what's going on with them now. And if you're handing off within your team, it will often be more abbreviated. So your senior should know these patients, you know, very well. So if you're handing stuff off to them for your day off, that's a different handover. But anything within teams, any new patients, anything to night float needs to go through the whole process. But again, it can be abbreviated. But that's where also knowing what actually is important comes into play. That's a good question, though. Any other questions? Okay. So this should be concise. It should focus on active issues. We are medicine doctors. People have problem lists that are 20 things long. Legitimate problem lists that are 20 things long. They have med lists that are double that length. So understanding what is important, what is likely to come up during the time that you're gone is a skill. It's hard. You will ramble. You will miss things. You will include things that aren't important. You will fail to include things that are important. It's a work in progress. Give yourself a break. You know, look for feedback. But I think the P is the hardest part. At least it is for me. All right, so it can be flexible as long as it's complete. Again, sort of to your point, this is not a helpful figure other than it just says the headings, but because all the words under it are gibberish, which I didn't realize until I blew it up. So you can do it problem-based, you can do it plan-based, as long as it includes something about who they are, why they came, what's actively going on with them, and what you're doing about it. Cool. This is usually the longest part. A is your action list. This is your to-do list. It includes specifics about the to-dos. So common things that you will have to do. You try to clean up everything before you leave. Do not get in the habit of being one of those people who leaves long to-do lists. But it's inevitable that you will have something that is lingering out in the world that needs to be done. So very common things are labs that need to be checked, like your DKAers that are going to have serial labs, your crits that haven't come back yet if you're trending, you know, GI bleeds, things like that. It's inevitable that you will have stuff that will come back after you have left. If it is something that you can follow up from home, I always follow it up myself. But if it's something that you are handing over to somebody else to do, it needs to be very, very, very clear. Because keep in mind that you're not going to be the only person giving them a to-do. So it needs to know exactly what it is and when you anticipate it. So we're going to take the example of a GI bleed. So you just handed over this patient. It's a 68-year-old gentleman whose diet consists of beer and BC powder. He came in this morning with upper GI bleed. He was scoped. He had an ulcer that was clipped. He's hemodynamically stable, tolerating clears. He has serial H&Hs. The last one came back at 6 p.m. It was this. His threshold for transfusion is this. We have put 2 units on hold for him. His next one is anticipated at 10 p.m. If it is below 8, he needs to get 1 unit. So it needs to be very, very specific. I need you to give him 1 unit would actually be the correct way to do it. So They need to know how important it is. They need to know they should do it no matter what. It's not like they're going to pick and choose what they need to do, but there are times where they'll be super in the weeds and they need to know if something is critically important. They need to know when you're anticipating this thing is going to happen, and they need to know what exactly needs to be done. It's also really important that you let them know what orders have been placed. So saying this guy needs to be transfused if his crit drops below 28 is insufficient, okay? Because that doesn't tell you if he has trending labs. It doesn't tell you when the lab's coming back. It doesn't tell you if he has blood. It doesn't tell you if he has order for blood. It doesn't tell you if he has blood consent. So all of these things add up for your night float for things for them to do if you don't do it on the front end. So have all the orders in. When possible, have standing orders for things that they may need. A lot of times, blood's a little bit tricky because you do have to consent. You still have to consent by a physician, Dr. Carey? Yeah. So we went to, and this is a national quality thing, but you have to be consented by a physician to get blood. So if you have a patient you anticipate needing blood, consent them before you go. That way your night float person doesn't have to go to another part of the hospital to consent them. And do as many of the orders as you possibly can. So this will come in place for common things. I really, again, urge you to do what you can before you leave, because you know the patient, you know the family, particularly if it's a family update thing. You really should not be having other people do your family updates for you. You have a relationship with that family. But obviously if something else arises and your night float needs to know about it. But the point of this portion, the point of the A, is that it needs to be very actionable and it needs to be very specific, okay? And it's not that your night float doesn't know how to replace blood. Like it's not belittling. You're trying to reduce the amount of work that they need to do, and you also want done with your patient what you had planned for your patient. And so the more specific you are, the more likely that is to happen. Does that all make sense? Okay. So think about the orders. Run yourself through the scenario of the thing you're asking them to follow up. If this comes back this. You'll run into it a lot with serial sodiums too. So if it's above this, do this. If it's below this, do this. If it's below this, call nephrology. They need to have a specific. And that's stuff that also can go in your written as well. A lot of patients, ideally the vast majority, will not have an action list for night. You need to save the phrase, nothing to do or nothing to follow up. Okay, that checks the A box, okay? This is part of getting in the habit of doing this completely, okay? So, again, on kind of pacing and the time that this takes up, a lot of patients, this should take 10 seconds. Nothing to do on this patient, nothing to follow up on this patient. But get in the habit of saying it. Good deal? That's good on me? Okay, we're getting there. Okay, so first S is situational awareness and contingency planning. So, we're not going to talk as much about the team level right now because that's a whole separate lecture about team dynamics and safety. But obviously knowing what's going on with your patient is important. It's why you're here. You are their doctor. This is important. But the IPASS portion of this is communicating that to other people, to people who have not taken care of this patient, to people who have not seen this patient, to people who may never lay eyes on this patient. And you need to understand kind of what's going on with them in general. So this is really where coming into an anticipatory phase of your assessment comes in. So a lot of times this isn't as concrete. A lot of times this is a lot of times an extrapolation or expansion on that initial stable, watcher, unstable assessment. So you need to know kind of where they are in their disease process. So for our GI bleeder, he was clipped. He's been hemodynamically stable since then. We anticipate that he'll advance his diet tomorrow and maybe go home on Friday. This is kind of an assessment of where the patient is in their disease process. COPDer came in, tubed in the unit, transferred out a couple of days ago, has been doing well on the floor but still needs BiPAP at night. And that's where you're assessing where they are. So you're improving, but you're still not quite there on where they are and how they're progressing towards their goals. So effective contingency planning is the second part of this. So knowing what's going on with them is one thing, and knowing what your plans are if X, Y, and Z happen is the second part of this. So if you're concerned about something, if you have a hunch that something may go wrong, if you've been getting calls during the day, which is the most predictive thing, if you've been getting calls from the nurses during the day about an issue with that patient, you need to know what to tell the person you're handing over to do about that issue, whether it's an issue that's happened yet or whether it's just an issue that's been in your mind. And you'll start developing these. Your brain will start working this way because you'll look at somebody and you'll say, you're not looking great to me right now. I'm going to do X, Y, and Z, and if it doesn't get better, then I'm going to have to go to D, E, and F. So you want to articulate concerns and what might go wrong. So I'm going to continue using different examples just so you can see what this, and these are off the dome, so don't tie it to individual patients, but you'll run into this with things like pain and agitation. So if you have a patient with delirium, if you have a patient with mental health issue, and you've been getting calls during the day, and you've tried several things, and you now have a good idea of what works and what doesn't, that gets communicated in your contingency planning. So it's helpful to night float to know that Geodon didn't work when you tried it at 10 a.m. It's helpful for them to know that this patient does not need, additional doses of morphine. It helps them to know that this has worked, this hasn't. It helps them to know that you're trying to get them off of this medication. So define the plan. List things that have worked, things that haven't worked, and then identify resources. So, delirium is a very good example, and the resources are not always medical. I've had patients where if you could just call their daughter and have the daughter, put the daughter on the phone with the patient, that helped tremendously. So knowing your contingencies, knowing what things that you want them to do and want to avoid. For patients that are truly stable, the kind of buzz check the box phrase is I don't anticipate anything will go wrong. And again, hopefully that's the case with a lot of patients. And again, once you get more comfortable with this, there will be more patients that fall into this bucket. But the list of things that you may be concerned about on patients is very broad. It's very diverse. It goes from the range of truly medical and potentially critical all the way to the range of this person's not very nice, and you should be aware of that in case you get called into the room. And all those things happen, and they're important in their own ways, but it's just kind of just a part of taking care of the patient and taking care of who's going to be taking care of them while you're gone. All right, any questions on situational awareness? No. All right, so the last part is synthesis. This is the part, too, you need to hold your partner accountable for. So the person that you're handing over to does not get to stay silent during this whole thing. They need to say something back to you. And it should be the things that are most important. So if they say something back to you, and it's amazing how often if you press somebody to do this, they don't hit the points that you wanted them to get. And so at that point, you're like, I need to reiterate this because this is what I really thought was important, and I thought that I was giving that information to you, and it clearly didn't quite come across. So you need to make sure, and they do not need to repeat everything you said. But particularly if it's something that you're following up or somebody that's unstable or a specific problem, they need to say that back to you. It's also their opportunity to ask questions. So some people do this as you go along. It is more seamless and more efficient for them to do it at the end, but they need to feel comfortable asking questions to you. And it allows them to have an active role in the handoff process. You guys know from having sat in rooms and had people talk at you for a while, you get more out of something when it's a two-way street. All right. Any other questions about that one? Okay. This can be quick, but it needs, particularly for patients that have stuff going on, you need to make sure that they're picking up what you're putting down. And again, a lot of times it's like, you weren't even listening. And that's okay. Everybody's had long days, it's exhausting, and maybe the 25th patient they're getting handed over. But if you need them to know something, this is the opportunity to make sure they know it. Cool. All right, so handoff is a team sport. I know I just said that one person needs to be handing off to another. I'm not contradicting that. I'm saying this in a general sense. So ideally, the entire team would be around for your handover. While it is only taking place directly between two people, meaning one person should clearly be giving the handover and one person should clearly be receiving it, ideally it would be great if everybody could your intern and senior, when you're getting the handover, particularly at the beginning of the year, if there's a lot of stuff to follow up on, having a brief powwow after you've received all the handovers to divide and conquer is really important, because the assumption is that if you are receiving the handover, that you are following up on the action items, and if that is not going to be the case, that needs to be clearly stated. Because you do not want a situation where you're like, oh, my senior was standing right there, they commented on that crit, they're going to follow that up, and then they don't, and that's a problem. So agree on your roles, identify any holes in the plan. There's some situations where you will be handed over a patient who is unstable. That patient needs a little bit more attention. A lot of times if you are able to go examine that patient before things get crazy at night, that is usually a good idea, so you can continue to fortify your mental model of them, and then reading back and verifying any particular specific action items is a good idea. Okay, so these are just kind of a couple of questions for you guys to ask yourself. I will not pretend like we are perfect at this. You guys will be more fresh on this and more complete. You guys hold your seniors accountable, hold your attendings accountable for doing this the correct way. So from a program standpoint, some of this is reiteration, but our expectations for you are pretty simple. You need to do this in person. It needs to be in the quietest place possible, understanding that it is not always possible to be in a quiet room with 2 people. It's just not. But make an effort. Don't just do it wherever you land. They should always follow the IPASS formula. We know there's a learning curve. You're going to forget stuff. You're going to get things out of order. That's okay. But have somebody help you out, particularly in July. Anybody who's consistently not doing this, shoot me an email or text me or tag or text me. I will leave you out of it, but we need to know if this is something that people are thinking that they're above, because you're not. I am not above it. Dr. Gary's not above it. We need to be doing this correctly, because we need to hold ourselves to that standard. And it's a pride thing, taking pride in your patient care and your team and your program. But I know you guys are all going to be fabulous at it. Sometimes seniors get a little older and a little wiser, and they think that they're beyond this, and we need to make sure that they're setting a good example for you guys and holding themselves to that standard as well. All right, so these are a couple of things about team steps and other handovers that I'm not going to go into now because it's a little bit in the weeds, but practice makes perfect by the great Bruce Lee. Do it over and over again. It will get easier. The pieces always change because every patient is different, but in a way that really helps as well. One of my favorite sayings is, you're going to be a bear, you might as well be a grizzly. These are my bears. But if you're going to do something, do it well. Show up, do it well. This goes for everything that we're going to tell you about, and this goes for this, even the stuff that's really easy to be like, oh, this is just, this is one of those stupid things they're making us do. If you need more data on why it's important, holla at me. I got a whole folder about it, but I decided I shouldn't put you all to sleep the first time. And if you have any questions or you need any feedback, just ask us. It's one of these things I'm still working on too, because it was implemented after I finished residency, so it wasn't something that I got as many reps on as I would like. But it takes reps. You need to do it, and you guys will get better at it as time goes on. Cool. All right, questions? All right, it's good to kind of informally meet you. Again, I'm around. Holler if you need me, but we're here to help. All right. Who's next? Cool.
We're like around 24. Cool. We're all running on that. Yeah. Yeah, no, our car at all. That's just jumping on that. Your wife medical? Yeah. She did work for Concept. Congratulations. She's at home. Fair enough. For now. How do you agree? How old? How old are you? 3. It's were they your first kids? No, we don't. They kind of do that. You're getting out. I feel like staying like 4, 5, 6 months. Yeah. There's good things about this. But it was like perfect timing because I was going to get home for not a whole lot of yeah, it is. No, but it's kind of supposed to be. It's a full spot. No, that's just from Alabama on. Yeah. She but Will, I guess she went back to Kristen to Alabama. Yeah. Oh. Yeah. But they're in the I didn't actually have. Yeah. I'll just come up and send it. Perfect. That's awesome. Well, welcome. We'll get to meet you then. Thank you. You have a restaurant. Sure. Good to meet you.
an income.